Hi, everyone. Good morning. Thank you for joining us. My name is Ilana Garner, and I'm the Communications Director for the Department of Neurosurgery at UCSF. And I'm going to be moderating this morning's discussion on motherhood and neurosurgery. So thank you so much for being here. We are going to put up a quick poll during this introduction so that we can get a sense of who you are. Looks like, yep, we are 56% medical students, some undergrads with us, residents, fellows. We have a great mix. If you are a Twitter user, our hashtag for this is neurosurgery mom. So if the panelists have some encouraging advice that maybe you'd like to share and help us draw some attention to this topic, you can do that if you do the tweeting. So without further ado, I'd like to introduce our first panelist, Dr. Lola Chambliss. She's an associate professor of neurological surgery and radiation oncology at Vanderbilt University, as well as the neurosurgery residency program director there. Her clinical specialties are in brain tumor and skull-based surgery. Her research focus is on machine learning approaches for predictive modeling and neurosurgical outcomes, which is awesome. And she has two daughters, Harper, who is 9, and Sims, who's 7. Welcome, Dr. Chambliss. Thanks for joining us.
Thank you. It's a real privilege to be here, and I'm excited that this event's taking place.
All right, next I'd like to introduce Dr. Lauren Sand, who's the incoming neurosurgery chief resident at the University of Minnesota. Dr. Sand has completed a neurointensive critical care fellowship, and after graduating next year, she's going to be going into general neurosurgery practice with a focus on neurointensive critical care. Her research interests are in neuro-ICU related protocol development and quality improvement. And she's mom to Gabriella, who's 2.5, and William, who turned 1 yesterday.
Oh.
Welcome, Dr. Sand.
Thank you all for being here. Very excited.
Okay, from our home team of UCSF, we have Dr. Wang with us, Dr. Doris Wang. Dr. Wang is an assistant professor of neurosurgery, and her clinical focus is in functional neurosurgery. She's also the PI of a lab that studies the neurophysiology of patients with movement disorders and the use of novel neuromodulation paradigms to restore function to patients with neurological diseases. And she has a 5-month-old baby girl named Skylar. Hi, Dr. Wang.
Hi, Elna. Thank you so much for putting this together, and I'm beyond excited to be here.
Awesome. And finally, I'm happy to introduce Dr. Catherine Miller, who is also an assistant professor of neurosurgery here at UCSF. And she specializes in spinal disorders, and her research focuses on clinical outcomes and quality improvement. Dr. Miller's daughter is Rain. She's 2 years old, and her son is Roman, and he is 11 months old.
Hi, everyone. Thank you for being here, and thanks for having me.
I'm excited to get into this with you guys today. This is we have a really great panel. So I think we're going to begin at the beginning, which is deciding to have a baby in the first place. And I think we have a poll question for our audience about when they are thinking they would like to have kids, if they would like to have kids. So before we get started, at the beginning of each of our agenda topics, we're gonna poll the audience to see what they have to say about the topics before we get started on them, and that'll give our panelists some idea. Great. So it looks like 82% of our audience are planning on having kids, a few undecided, and looks like residency research year is the most popular year that they'd like to start having kids. Some residency, some faculty, a mix, which is great because we have a mix here with our panelists today. So the first question is, how did you decide during your career when you wanted to have a kid? Dr. Sand, do you think you could kick us off?
Sure, happy to. So, for me, I felt like there was no right time necessarily to have a kid. Fortunately, I met my husband when I was a first-year resident, so there's that part that is needed mostly. And then after that, I had my first child during residency, during my research time, which was my 4th year. Part of it, is the question of, are you going to have issues later on with fertility or not? And we were very fortunate in that we were financially able to have kids in residency too, which is also a huge issue that you need to factor in. So for my family, it worked out best that way. And I've had 2 during residency so far. And we'll see what happens. I have 1 year left still.
Yeah, that's a really great point that you bring up, because most residents are, in residency during their mid-20s to early 30s, which is also when most women, at least in the United States, are having kids, and that's probably maybe even shifted a little from peak fertility for most women. So I think that that's an issue that maybe doesn't get discussed as much. So I'm curious to hear, Dr. Wong, how about you? How did you decide on when was the right time for you to have a kid, and was fertility something that came into it for you, or not really?
Yeah, so I when I went into neurosurgery residency, I had no plans on having children. I mean, I haven't met my husband then, so we got married, I think, during my research year, and he really wanted to have children and start a family. So that definitely changed my mind. And being in the Bay Area and with both of us starting our career, it was a little challenging in the beginning, just to figure out the timing. Again, as many people said, there's no great timing. And I think for us, we wanted to be in a financially stable situation. And since he's also an academic neurosurgeon for us, and a couple years ahead of me, so for us to have job stability on both sides, that was really important before, we started considering having children. So, we just had our baby 5 months ago. So it's a little bit later, and, you can't plan for everything. Certainly this was a planned pregnancy, but it took us a little bit longer to get there.
Dr. Miller, do you want to comment?
So my situation is a little bit different. I didn't meet my husband until kind of later in my residency. So since I wasn't with anyone during residency, it didn't really cross my mind. I did worry about fertility though, because I'm a little older. I took a couple of years off in between medical school, or between college and medical school. So I actually did kind of the whole workup fertility wise about possibly freezing your eggs. I went to a doctor, did the labs, all that stuff. So I had all the information had I planned that I wanted to do that. And then oddly enough, weird how things work, I met my husband, a few weeks later. We started dating and things got serious. So then I didn't end up freezing my eggs, but I had actually gone through the whole process up until actually doing it, thinking that, at some point I wanted to have a child down the road. And I always just kind of had the fertility issue kind of in the back of my mind, worried about that. And then I actually got pregnant during my fellowship. We kind of talked about it. Do we want to have a baby sooner in my career or later? But I kind of chose sooner because I figured I wouldn't have that much going on. It's probably a better, time to take off some time for maternity leave rather kind of than being more established in my career. And I felt like it'd be harder to kind of rearrange things or reschedule, to take that maternity time off.
Interesting. Dr. Chambliss?
Yeah, so I think one point I'd make is that, we don't always decide when we want to have children. And we might think that we can control that, but a lot of times you can't. And that can, that can affect you in both ways. So I knew that I wanted to have kids. My husband did as well. But our first was a bit of a surprise in terms of the timing. And so I ended up getting pregnant as a chief resident. We had thought that we would probably wait till after I was done with training because I was doing an international fellowship and he was not coming with me for that. So that was a surprise. And in the end, it worked out great. I had my daughter at the end of chief residency, and then she and I and a friend who worked as my nanny moved to Australia, and we did that. And then we moved home, and then it actually was fantastic because, I was ready to have children emotionally and, and in my relationship, but it just kind of kick-started me in a way because I was really making the decision to wait because of those career issues. And it turned out that that wasn't really necessary. And then we had our second daughter pretty close after that because I knew that we wanted to have 2 and I wanted them to be pretty close together.
So how was it, being with a young child, being international? without much help.
Yeah, so that was definitely the hardest part of my life, I would say. You know, she was actually a month early, which was helpful. So she was just barely 3 months old when we moved to Australia, and she didn't sleep through the night, you know, for the first 3 months there. I was working a ton, and so I had a nanny living in with me. But you know, when during the nights when I was at home, you know, she needed a break, so I was doing the up all night stuff with the baby while on call every night for my entire fellowship. So it was, when I look back on it, I'm like not entirely sure how I survived. But you know, you do what you have to do, and it was critical to me to do that fellowship for the job that I was taking. And I'm a skull-based surgeon. I was doing you know, highly regarded, minimally invasive skull-based fellowship, and I needed that to be in my academic position that I have now. And so you just, you know, you find a way to make it work.
You, as a residency program director, when women who are interested in neurosurgery come to you, do you advise them at all to do like fertility counseling or any of that kind of stuff if they feel like that's something that they want, but they're not sure really? Maybe they don't have a partner yet, or maybe they, you know, that sort of thing, sort of like Dr. Miller did. Is that something that you advise people to do?
Yeah, I mean, as a program director, I think you have to be really careful not to make assumptions about what anybody wants in their life. And so I try to open those conversations kind of carefully, because sometimes those things are so private, it's not something that even a mentee necessarily wants to talk to me about. And I have to be especially careful about that with my own residents, because, you know, I have a role for them that is partly mentor, but also administrative and managerial. In reality, all of my female residents, I think, have mostly wanted to talk to me about that stuff. And so we do get into those discussions pretty often. I was the first woman in our department to ever have a child, and I'm now the program director for that same department. Since then, we have had many more, and things have changed in terms of the way that we manage that, and that's been really intentional. But yeah, those conversations about fertility are important, and also conversations about how to, you know, how to make the decisions about timing and that, you know, and how to handle the conversations with those around you related to timing, whether you're in our department as a resident or wind up elsewhere.
Mm-hmm. Great. So maybe we could shift the conversation to actually being pregnant now. So now you've decided you're going to have the baby, or it was an on the fly decision maybe. And you find, either way, you find yourself in this pregnant. What is it like being a neurosurgeon and being pregnant? I mean, this is like a very physically demanding job. Yeah. Especially during residency, I would imagine. So what is it? Yeah. What is it like? What was your experience like being pregnant? Dr. Wong, do you want to start us off with that?
Sure. So I guess I had the fortune of being going through the first trimester during the pandemic. So when everything was shut down on Zoom, so it's a lot easier to handle the constant nausea and throwing up I was having. So that was actually kind of lucky. But you know, later on, I was doing, you know, pretty large spine wax, and then even doing like functional cases where I'm wearing lead constantly, and while carrying, you know, 20 to 30 extra pounds on me. That was really tough. I mean, it was physically demanding, but I think what I found is everybody is super, super supportive. And all our nurses, my colleagues, residents, you know, whenever they see me on my feet, they actually like tell me to sit down, try to bring me a chair and such. So that made it a lot easier. And to be honest, having the pandemic, being able to work from home or in the office virtually, that has helped a lot as well.
With the lead that you had to wear, Dr. Miller, I think that you mentioned that you had the same issue because you do a lot of spine cases, so you're wearing lead all the time when they're doing the imaging, right? The real-time imaging, and how did that work out for you?
Yeah, that was kind of difficult. I mean, by the end of the day, you just, you know, want to sit down or go to sleep even. So I think I tried to find the lightest lead possible. that kind of wrapped around you. And I hid it all the time because, trying to find lead sometimes if you don't have your own was a big issue. So that was one of the things kind of right when I got pregnant that I like found great lead, hid it. Then at the end of my fellowship, Dr. Mumaneni actually bought me my own lead. That was like maternity. So it had the extra, little compartment in there. But that was a huge issue. And I think at least being busy for me helped because it kind of took my mind off it when you're kind of, in the middle of a surgery and you're, operating and kind of an intense moment. I just didn't think about it. So that helped a little bit. I also had the pleasure of having morning sickness until I was 40 weeks for both kids. So continuous every single day. And so that's terrible, but being super busy, I just didn't even think about it. Just like you don't think about if you have to go to the bathroom or things like that. Sometimes you just get so engaged in the surgery. So at least in the beginning, because it was the first 6 months of my first pregnancy, I was so busy. I just couldn't even like think about some of these things. And then by the end of the day, you're just like, oh my gosh, I'm exhausted. So.
Mind over symptoms.
I think one thing that everybody should be aware of is that there's actually a lot of data to suggest that female surgeons have a much higher rate of preterm labor and premature delivery than age-matched controls. And the hypothesis there is that it has a lot to do with the amount of time that we're on our feet and that, of course, additional stress, but truly it's present in surgeons and not in surgical residents more so than in other non-interventional fields. I had a preterm delivery with my first child and not my second as an attending. And I think it was much easier to be pregnant as an attending because I had so much more control over not just my day and my schedule, but even every moment. If I needed to leave to go to the bathroom, I just let the resident keep working, and that sort of thing. But I wondered if anybody else here experienced that in terms of pregnancy-related complications or preterm labor because we've had that problem with residents in our program too.
To piggyback off of that, I didn't end up having any complications, but both of my pregnancies were during my residency. And so like Lola just said, it is different because you never want to be the person leaving before your attending is leaving from the OR. So there is that kind of stigma that's there. And like she said, the risk of having preterm labor is still present though. So the more and more that this becomes normal, I think the more that it'll be understood that this is the way it is. And if you need to leave, you need to leave. By my second pregnancy, it was actually a little bit different. My second pregnancy when it happened, and I was visibly pregnant in the OR. People were much more accustomed to that point, at that point, to giving me a chair, telling me to go to the bathroom because it had become a normal thing at that point, a little bit normal anyway.
So Lola, does your institution have a policy or any guidelines about, women being in late third trimester, residents not peeling back their duties or any accommodations that you guys make?
We don't have an institutional policy, but we certainly, I certainly work as a program director to talk to those residents and the other residents about how to ideally schedule their time. It's always a balance between, educational needs and training needs and, your physical well-being. And if anything, in my experience and knowing other women neurosurgeons elsewhere, like the challenge tends to be trying to convince them that they need to take a break. More so than people saying that they, want a break and it doesn't make sense, right? Yeah. And so that's a challenge for me because I don't want to be heavy-handed and, paternalistic or maternalistic, and tell people what to do, adults what to do with their lives. But on the other hand, it's really important that they feel strongly supported. So I think that it's rare to probably have an institutional policy related to that, but it's certainly something that residency programs and really need to focus on from the leadership level.
Do we have any practical tips for people who are considering pregnancy during while being surgeon? Like, there a brand of compression socks that you would recommend? Is there, like setting reminders for drinking water? Like, what did you have any practical kind of things that helped you?
Well, I'll say, don't forget, you can throw up in the OR if you need to, just in one of the trash cans. So, and then you need to break scrub and scrub back in. But sounds like Catherine may have had that happen quite a bit to her during her pregnancy. My second one was like that, and sometimes you just gotta turn around, throw up, start over again. Scrub sinks at my hospital have seen me do that many times.
Catherine, did that happen to you?
Oh yeah, numerous times. Everyone kind of got used to it by the end of it. They're just like, oh, okay, yeah. But I think at least tips for people, like I said, like setting a reminder, because no one else is going to make you do these things, whether it's drink water, go to the bathroom, things like that. And so I think you kind of have to be your own advocate. Like I said, once you're really pregnant, people obviously are very much aware, but in your earlier pregnancy, and if you're not telling people, because I didn't tell people until after I was into my second trimester both times, you can't tell sometimes, especially if you have lead on. So no one's going to, make you go and take these breaks. But I think, you have to realize kind of your limits. And maybe even kind of think about your day or try to pre-plan if you can kind of, in between these cases, maybe I can, get some food and a drink of water, things like that. Because, if you don't think about it by the end of the day, it's 6, 7 p.m., you haven't drank anything all day, you haven't gone to the bathroom. And obviously that's not good for you or the baby. So I think just trying to be your own advocate, take the time for yourself, everyone's going to understand. It's not like you're going to be punished for having a bathroom break or anything like that. But again, no one's going to make you do it. So that's just one of the things to think about.
That's a good point that like Dr. Miller is bringing up. Just those little tiny things can make a world of a difference in your day. Grabbing those patient crackers and juice between cases, it makes a world of a difference for your nausea, for your hunger, everything. So you don't pass out in the OR. Just having an internal kind of reminder of those things is important.
One of the things that I think is so important that we can do as faculty and as senior residents too is try to model the importance of self-care during surgery for all surgeons. So, I take breaks. I do long cases and I take breaks and I go get something to eat or drink, or sometimes I go stare at the New York Times on my phone for a little while, because I'm a better surgeon when I, able to recognize when I need to stop focusing on what I'm doing and hand it off to my co-surgeon if it's an acoustic neuroma, for example, or let my resident work for a little while. And so I try to also send the residents away for breaks. And I think that's something that we can do to our male and female residents that kind of normalizes that behavior and the recognition that you're a human being with physical needs, and that the best surgery happens when you're at your best.
Great advice. So Dr. Miller, you said that you didn't start telling people until you were into your second trimester. Is that sort of true for the rest of the group as well? Dr. Sand, did you tell people maybe earlier because you had to make plans for your training? How did that affect your training?
Our program is 2 residents per year. And so it really does affect your co-resident and the residents that need to cover for you. So I tried to give them a little bit more notice. My first one, it didn't matter so much because I would be having that one when I was in my research time. So nobody would be really responsible for having to cover me for the most part, except for holidays. But for the second one, I told them pretty early. I told them around 8 weeks, I believe, just because I was trying to kind of look out for my own cohort more than anything.
Dr. Wong, when did you start having those conversations with your colleagues? Or
I think pretty late, 5 or 6 months into my pregnancy, because again, this is kind of in the pregnancy in the time of Zoom. I actually didn't physically see people. So it wasn't until when I needed to arrange for coverage And, to everyone's point, my OB was really scared about preterm labor in somebody, who has had complications with pregnancy before. So, I need to make accommodations, make sure I'm not on these crazy call schedule during my last month of pregnancy.
Mhm.
So I told people pretty late.
So it sounds like when you came back to work, everything it was a pretty supportive environment as well. Um,
Yeah, for me, it's been amazing. I mean, all my colleagues, again, I think it's different, right? And now as an attending in a very supportive environment, my colleagues, and even my chairman told me, you should take all the time that you need. Don't feel the urge and obligation to come back to work early. And of course, being type A, like everybody here, I didn't take the full maternity leave, the time that was allotted to me. For one thing, I have a lab and I need to keep that going. And a lot of the things I can do, again, it's nice with Zoom being available, so you can really try to multitask. And I had help with childcare as well.
yeah. So at UCSF, I think the policy, there's a question up for the audience now about taking leave. So the FMLA, the Family and Medical Leave Act, requires all employees to provide 12 weeks of unpaid parental leave to all eligible employees. I think at UCSF, if you're a faculty member on our compensation plans, you get 12 weeks paid. And if you are a resident, we have sort of a newer policy where you get 4 weeks paid, and then you can take vacation and sick leave on top of that, and then you can take any remaining unpaid FMLA time after that. So that's sort of what we have going on here at the moment. And I'm curious to know, at Vanderbilt and University of Minnesota, is it similar or different?
So one thing to know is that a lot of residency programs are probably in some flux about this because of the recent new guidelines published by the Association of American Medical Societies, I think, which is kind of the group of all the specialty boards that recently, published a suggestion that all residency programs or training programs longer than 2 years should allow for a minimum of 6 weeks of paid parental leave, but did not come out of vacation and sick time. And so I think a lot of institutions are in the process of adopting that. Previously, we had parental leave that started with vacation and sick time, and then if you extended past the time that you had that time available, it went unpaid. But that is changing for us now, I think, in a really positive direction, and it aligns now with our faculty parental leave policy, which is 6 weeks paid for faculty before you start getting into vacation and sick leave beyond that. And interestingly, it's state dependent in terms of FMLA. So in Tennessee, you actually have up to 16 weeks of leave that's not necessarily paid, but it's guaranteed for you.
For the University of Minnesota, it may be changing. I wasn't aware of that new change that is occurring now, but what it has been at the university is that there's 6 weeks paid leave for both paternity and maternity leave. They're the same. And then after that, it seems like it's mostly up to the discretion of the department after that. For my first one, I ended up taking 12 weeks just because I was on research. So it wasn't, I still worked throughout it, but I would be working at home anyway, mostly. And then my second one, I did 6 weeks.
6 weeks.
Yeah, while I was working.
It looks like we polled our audience to ask them how much leave they would ideally like to take, and I think 8 to 12 weeks, followed by 12 plus weeks. So looks like those were the most popular results.
And the second piece of this that's critical to understand is the whether this impacts the length of your training. And so the ABNS, the Board of Neurological Surgery, has one of, I think, the absolute best policies for surgeons of all residency programs for surgeons on this subject. So essentially what they say is that you take whatever leave you're going to take for parental leave or other FMLA needs. So if you're injured or you have a family member that has a terrible illness, you take the time you're going to take. And ultimately, whether your training is extended is at the discretion of your program director, which means that the program director can change things around in your schedule to make sure that you're getting the appropriate time. And as far as I know, the vast majority of neurosurgery residents have not had their training extended because of parental leave. That being said, the one maybe flaw in that system is that if you have an adversarial relationship with the program director, potentially, you might feel that you were being told to extend your extend your training when it wasn't absolutely necessary. I've not heard of any of those situations, but I think that if that did occur, that's something you would have to take up with your DIO, which is the institutional officer in charge of GME. But I will say that the ABNS made this change a few years ago, and it's a really good policy for neurosurgeons. And a lot of medical students that I know that are interested in neurosurgery are unaware of that. We actually have one of the most progressive policies in surgery.
That's actually a very good point. At the University of Minnesota, our program directors, both that have been while I've been here, have been very open to that. And I haven't had to extend my training, even though I've had 2 kids during residency, based off just whether or not I've met all of the ACGME requirements in order to graduate so far. And as I'm sure most of you that are watching this know, you log your cases on ACGME case logging. And as long as you are kind of following consistently with where you should be, most program directors seem to let people continue and graduate at the appropriate time.
And the reason that's so important is because if you're going to do a fellowship, for example, and you don't graduate on time, you can't do the fellowship that year, probably. And so, while extending your training by a month may not be a big deal if you're not doing that, that issue was really going to keep women out of academics, I think, and out of subspecialty training. So I think we're really lucky to be in a position where our leaderships recognize the importance of that.
Definitely.
Dr. Miller, how did you take your full 12 weeks of parental leave, or?
I did. Yeah, I took 12 weeks for both of my kids. The first one, I don't have any family in the area, so it's just me and my husband, and getting accustomed to having a new baby where neither of us obviously have that experience. I mean, it took a while to get used to. And then I feel like I just didn't feel like myself or kind of mentally or physically back to normal by 6 weeks. So I applied Doris and Lauren for going back at 6 weeks. I wasn't there yet. So I took the full 12 weeks. It flies by. By the end of it, I wish I actually had more time. And my colleagues were amazing. So had I wanted to extend, I think they would have been more than happy to back me up or things like that. My second child, it was during COVID. So I actually worked the whole time too. I did all my Zoom clinic visits and I did a bunch of outpatient stuff. I didn't operate, I didn't take call, but I was kind of semi-working the whole 3 months. So I didn't feel, as guilty about taking it. But then again, I shouldn't really feel guilty. It's my time to be spending with my family. So, but it's just kind of one of those inherent things, like, I know I shouldn't feel guilty, but I still did. So that's why I tried to do all my, didn't want to put any extra work on my colleagues, as far as clinic patients and stuff. So I feel like there's, take as much time as you want. That's what I would tell people. Like, don't feel rushed to go back, because depending on what type of delivery you had, you might not be ready to go back after 6 weeks. And like I said, dealing with a new child, getting used to it, not sleeping, not eating, it wears on you mentally and physically. And so if you need that extra time, I would say do it. Cause I did it, I'm glad I took the 12 weeks. And if I ever have another one, I would probably take 12 weeks again. So.
Yeah, with my first, I took about 10 or 11, I guess, in the end, because we were moving to Australia. I'm not even sure. But with my second, for some reason, even as a faculty member, I went back at 7 weeks, and then I flunked, and I was back out again because I got really sick. I got mastitis. I had to be readmitted to the hospital, and I had to go out for another week or two, and then I was back, but I was really not myself. And in retrospect, should have taken more time. And I don't think it would have really been that difficult on my partners, but I was kind of gung-ho that I needed to make this as minimally impactful on everyone else as possible. And it wasn't very smart.
Also, there's a huge difference between a 6-week-old baby and a 12-week-old baby. For those of you that don't have a baby already, the 6-week-old barely has any fat on their bones yet. So it's really hard going back at that time. And at the same time, like Dr. Chambliss mentioned with the mastitis, it's hard to keep up your production if you are breastfeeding and you go back at 6 weeks opposed to 12 weeks, at least for me. So if you do have the opportunity to stay longer, I think that would be, I would prefer that as well.
And to Catherine's point, the guilt is real. And like, that's a huge barrier. The way that I have tried to address that more systematically, because I'm done having kids, but so it doesn't affect me anymore, but more systematically in our department is by encouraging / almost requiring the men to take parental leave. We can get into that. I don't know, sort of a separate issue, but I think encouraging all people to take parental leave or take FMLA to take care of their families helps reduce the challenges for women on this particular issue.
That's a great point. Last year, one of our male residents took a 6-week leave, and it was almost, unheard of. The rest of the ones before him took a week of their own vacation time at most. And I think that that's a huge thing, making it a normal thing for paternity and maternity leave both going forward.
Yeah, what I always say to our residents is, in 7 years, everybody is going to have something affect their lives that is going to mean that they need to take a little bit of a break from work, whether that's death of a family member, personal illness. We had somebody who lost their entire house to a flood during residency, and needed a month to handle that. So like accepting that on the front end and then recognizing that pregnancy or delivery or adoption of a child, whatever that may be, is just one of those other life events that you're going to need to be prepared to take some time away from work to take. Kind of evens the playing field and makes this less of a specific issue.
What would you say? Yeah, let's get into that and talking about like then coming back to work. And what would you say? How can people deal with it if they find themselves in an environment that's maybe not quite as supportive as the one that you're creating at Vanderbilt? Like if they, because I think the neurosurgery culture is very much like not really what you're describing. There's a lot of pressure to be there all the time, right? And so how would you advise people to advocate for themselves in that situation?
Yeah, that's a good question. And I mean, what I'm describing is kind of the idealized culture, and is we still don't get it right here all the time either. I think part of it is advocating for yourself, but it's also recognizing those around you that might be able to help advocate for you and asking for that help. If you can find those people. I'll say I've been that person for people at other institutions a few times, which was really enlightening to me, where women who are neurosurgeons in residency reached out to me because they heard about me from somewhere. I gave a talk about pregnancy and neurosurgery years ago, and I became like the token expert on it. But so women would reach out to me and say, like, I'm having this problem where I'm being told I have to come back, and like I'm still supposed to be on FMLA. And I actually had conversations with chairs at other departments to say, like, hey, this is illegal, just for your own good, don't do this. And so I think you got to be broad in terms of how you look for advocates for you, and that can be within your own institution or elsewhere. And then also the number one piece of advice I always have is like, know what you are legally entitled to before you start making your plans about what you're going to ask for and in terms of your leave, et cetera. Know what your own HR policies are. You can call them, you can figure that out on your own before you tell anybody that you're pregnant. And so, design a policy that you are, and if you don't have a policy in place at your institution, create that policy. That's what I did when I got pregnant. I figured all of that stuff out before I told anybody that I was pregnant. And I said, well, here's what I'm entitled to, and here's what the rules are, and here's what they do in general surgery, et cetera, et cetera. So here's what I would suggest we should do with this issue for me. And then, my program director was like, okay. And so, I think knowing what you want and what you can have is the first step to advocating for yourself.
I think as the culture is changing, now we have people, women, like Lola, who's now in leadership positions, hopefully that we can normalize this process for everybody, both men and women. And that's our goal. And I think having this conversation in a panel like this is fantastic. And hopefully we'll still continue to change things for the better. Yeah, I mean, I completely agree with everything you said. And we're trying to do that at our own institution as well.
And it's getting so much better. And I have a lot of friends in the program director community now that are men that you know, call me up and say, hey, what's your leave? You know, we really need to have better protocol about this. Like, what does that look like? And I think that the culture has shifted dramatically in the last 10 years that I've been involved in this kind of space. So for people entering the field, all these medical students and undergrads on the call, I think that, you got to know that there are a lot of people, men and women, who are advocating for this to be much better. So things are only going to improve from here.
So we polled our audience about what they are most concerned with about returning back to work, and about 49% of them said childcare was the number one issue that they were the most concerned with, followed very closely by career impact. So what was childcare like when you had the baby, you've come back to work? How did you deal with that? Dr. Wong, do you want to?
Sure. So I was very lucky. So my in-laws live in San Francisco, and my parents have been like egging me to get pregnant for a long time. So as soon as we had the baby, my mom was staying with us, helping to take care of her, and we actually got into UCSF daycare as well when she was about 3 months old. So that really helped with the transition. Having a childcare with really great hours. Like our daycare opens at 6:30 a.m. So it makes it possible for us to drop her off and still make it to the OR and the different campus in time. And, with pickup and stuff, yeah, we can kind of try to coordinate our schedules a little bit better. Like I'll pick her up on my clinic days, and same with my husband. So we can make sure we pick her up by 5 p.m.
That seems pretty ideal. We don't have a institutional daycare system. I actually tried to get one set up, and with residency, it didn't work out, but that is definitely an ideal situation to have. We were fortunate enough to be able to pay for a nanny, which is an arm and a leg, but she's been with us for 3 years, well, almost 3 years now for both of my kids. So we've been really lucky with that. And then this coming year, since it'll be my chief year, we're actually going to have an au pair in addition to a nanny. So it's going to be really interesting time. I know that a lot of people in neurosurgery have had au pairs, both men that have children and women that have children. So that's always an option too. And that is a little bit cheaper than having a nanny at home as well, if that's something that you're looking into.
Yeah, we were on the nanny side of things. I don't know how we would have survived without it, because certainly as a resident, even institutional daycare is often not adequate, because, like, for example, they might open up at 6:30 in the morning, and that's of course long after you've arrived at work. Plus, you don't necessarily want to have to bring your baby in at wake your baby up and bring them in at 6:30 in the morning. So we went with a nanny option, which we were able to afford. But I'll say there's something really cool happening in my residency right now, which is that one of our male residents who's married and has a daughter, his wife really wanted to be able to stay home with his daughter, and they're living on his salary as a resident. That's challenging. She wound up opening up an in-home daycare and the other 2 kids in that daycare are the daughters of my 2 female residents.
Wow.
So it is the neurosurgery daycare, and those moms or their husbands drop their daughters off with her every day. And, she's paid to run that. And she obviously, the woman who runs it is the wife of a neurosurgery resident. She gets it. She understands the, ups and downs of timing, et cetera. And this worked unbelievably for them. And these 3 little girls are adorable and thick as thieves. And it's just been tremendously helpful to that family, especially during COVID, when childcare was unbelievably difficult to obtain.
And I have just a little different situation. So we moved out for my fellowship from Minnesota. Like I said, no family, no one really, we didn't know anyone. And so my husband and I sat down and we looked at daycares, and I live just north of the Golden Gate Bridge. Some of the daycares cost more than my medical school do. I mean, I cannot believe how expensive they are, but I mean, we ran the numbers and I said, honey, either you have to get a job that you make X amount of money, which is a lot, or you could stay home. And I gave him the option and we talked a lot about it. And he said, hey, I'm going to stay home with the kids. So I'm super lucky in that my husband takes care of our kids. I don't have to worry about dropping off. If I have to get up in the middle of the night, I can just run. I don't have to be back in time to get the kids ready to go anywhere. I can stay late if my case runs late and not have to worry about, like I said, picking them up or anything like that. So I really enjoyed. I think he is enjoying it. With two, it's been a little bit dicey at times, but I think he likes being home. He gets to spend the daddy time with them, and then when I come home, it's mommy time. But it gives me so much flexibility in my scheduling because, you know, life as a neurosurgeon is crazy and I take call every other night. So, you know, my schedule is not, fixed. I don't know what's going to happen the next day. So having him do that, I think both financially works for us, but then also for my schedule. And again, some of my mommy guilt, like I want to be there with them, but at least I feel good that they're there with their dad. So, I mean, that's always an option. And it works for us. It might not work for other people, but that's, if you're thinking about that and you can swing it on one salary, then that might be an option too.
About your mommy guilt, about the sort of that feeling of, how are you balancing it? How do you like make it work? Give all the time that you need to your kids and at work. I mean, I think that the answer seems to be for a lot of people, like you can't, but I'm just wondering if maybe you could speak to that a little bit and people who may look at you and say like, she's doing it all and she's managing it. She has everything. Like, is that really what it looks like?
Oh gosh, no. So I think part of it as neurosurgeons, it's part of we want to do everything. We want to be the best at everything. I feel like that's just what type of people we are. And I actually just heard this on a webinar about gender inequality in academics, but you just have to accept imperfection. You're not going to be a perfect mom. You're not going to be you can't do everything perfectly at work. If you try to do perfectly at both, you're just going to wear yourself out. So that's one of the things I've had a hard time trying to adjust to, that I can't be there all the time, that you are going to miss some of the little things. But I have my husband very well trained with cell phones, that if there's anything that I haven't seen, first steps, first words, that he's going to videotape it. So that's helped a little bit. And then also, being able to do FaceTime with the kids. Like if I'm running late, I'm not gonna be able to put them to bed. I'll FaceTime with them, even if I have to like pause my surgery for a few minutes, I'm stepping out, I'm gonna go say bye to the kids and then I'll come back in. Everyone's fine with that, but at least I get my, goodbye time with them. So that's helped a little bit, but I mean, it's just inherent. Like you just want to be there all the time. And I mean, that's probably one of the biggest things I've had to deal with, trying to be busy and be productive, but also, be there for the kids.
Yeah, Lauren, I wonder how you feel about that, because I feel like it was my brief period of time having a child and being a trainee, this was the challenge. And then as an attending, I feel like it's been a lot easier. But how's that been for you?
Yeah, the mom guilt as a resident is definitely, it's really tough, because when you're a resident, you're not just doing the things that you want to do once you get there after graduation, but you're also trying to do the reading and the additional hours that you don't necessarily need to be at the hospital for, but really should be as part of your training. So that's really tough to get out of the 3 or 4 cases of the day, and then instead of rushing home, saying, okay, I have to read for that extra 30 minutes this chapter because I have a really big case that I've never done tomorrow that I really need to look into. So it does require a lot of discipline. And like Dr. Miller said, you never quite get over the mom guilt, but you do have to just accept that you can be imperfectly perfect at everything. And by the time that your kid is 2-3 years old and can start kind of understanding things, the reward is that you'll come home and they'll say, my mommy's a doctor, she saves people, so just keeping that in mind, it makes it all worth it.
I definitely have morphed my feelings on this a little bit during the pandemic, I think for the better. I've got the oldest kids in the group at 7 and 9. And I will say this gets easier as they get older because they understand that you're going to come back. They understand a little bit more about what you're doing. But I also, when things shut down and like my kids suddenly couldn't go to school and we had no nanny anymore, and I'm divorced, so I split custody with my ex-husband. But the times that they're with me, it was just me, and all of a sudden I couldn't go to work. It definitely forced me to get more creative, and it actually has allowed me now that even once they went back to school, et cetera, it's allowed me to carve out more of my time to intentionally be with them. And so, for example, Tuesdays are my academic day. And so, they used to be in school, and then I had somebody to pick them up, and, I'd be home at 5 or 5:30. And with COVID, that became really difficult to, find somebody who could get them routinely from school, et cetera. And so for a little while, I just was like, well, I just got to leave and go pick them up at 3. And actually that's what I've done all year. And so I pick them up at 3, and then we go to the nearby Starbucks where they do their homework and I do my CNS annual meeting call. And then we get in the car and we go to their swim lesson, and they do their swim while I run for 4.5 miles around the natatorium. And then I pick them up and we come home and we make dinner, and we have a great day together. And then if I've got stuff that needs to be done, it happens after 8. It can be stuff that can be done on the computer because it's academic time anyway. And that's kind of a game changer to me. It never occurred to me that I could actually do that. I almost hate putting it out there in public in case somebody finds out that I'm doing this in my institution. But it's worked totally fine. I still get the same amount of work done. It's just shifting it around in the day in a little bit more creative way, so that I'm actually there, doing that school pickup and sitting there and having, our croissants at Starbucks together. It's been really cool.
I think that in some ways what's happened with the world right now with COVID and Zoom becoming a more common thing has really been beneficial to us too. You see even men when they're on these Zoom meetings, their kids are running across the background, and still people are getting things done as efficiently as they were before. So hopefully this will become more of the norm for even neurosurgery.
I think during our prep for this call, Dr. Miller said something that really struck me that I think would be great to share, and that was that she said, when I'm with my kids, sometimes I'm worried about my notes at work, and then when I'm at work doing in the office stuff, I'm like thinking about the kids. But when I'm in the OR, I'm only thinking about what's happening in the OR. And she was like, it's my happy place. Like, it's my happy place. That's like, that's like the only thing that's in my vision. I'm only thinking about my patient and what's happening in front of me. And so if you're a trainee and you're interested in neurosurgery and you have this calling, like, I feel like do it.
That's so true. I don't know if it's the adrenaline surge or what it is, but everything else goes on pause.
And it's more predictable as well. And I think just, having being in the OR, it's like you can put everything aside, and it's my one time where I can actually focus.
Amazing. So I just wanted to move us a little bit forward towards when you come back. I know a lot of people had questions about when you come back, what the lactation situation is like as a surgeon. Can somebody, Dr. Wong, since you had your baby the most recently, maybe you can tell us about what's happening right now with the lactation situation in the OR.
Yeah, so it takes a lot more planning. So when I do a case, I think about pumping right before I go scrub in. And I use wearable wireless pumps in the OR. And I'm trying to, tell people, I tell my scrub techs, my nurses, my residents, and like, I'm pumping, I need to scrub out, stretch out the bags every 3 to 4 hours, and just trying to normalize the situation. And then in my office, I try to schedule clinic patients so that I can get a pump session in. It just takes a lot more planning. There's a lot more equipment, but it's totally doable. And yeah, my daughter's still being breastfed right now.
That's great.
I think that's so amazing. That technology did not exist 7 and 9 years ago. And I worked really hard to try to, pump for my kids as long as I could. In reality, starting fellowship in particular just wasn't doable at a certain point. And so my kids ended up getting breast milk for 3 months each and then transitioning over. And I'll tell you, for that first week where you transition them, I mean, I was like crying every day about how I was not, fulfilling their needs and that I, not giving them the perfect thing. And in reality, like I had a lot of experienced moms who were not neurosurgeons, but were like, Lola, like formula is fine. Like stop this insanity. And that was it happened to me twice. So obviously you don't learn the lesson the first time, but I think that was part of that letting go of some of the mom guilt, is knowing that like, if you can do that, that is fantastic and it's wonderful. And if you can't make it happen, that is also okay. And your children are going to be fine. And that's like a lesson for all of motherhood, because there's always going to be things that would be perfect for your children that you're not able to accomplish too.
That's a great point. For my first one, it was during residency research year, like I said. And so I was able to make it to 11 months for her breastfeeding exclusively. The second one, because I went back after 6 weeks, I only made it to about 3 months as well. I even had those wearable ones in the OR, was pumping next to my attending, hearing that sound pumping in there under the OR. Big guard. But yeah, I still only made it to 3 months, and I had a lot of guilt about that. Fed the other one the whole way through, not this one. I tried the rooms, like the lactation rooms in the hospital, which were 3 rooms for all healthcare personnel in the hospital. That didn't make it work. But now he was 1 as of yesterday, and he's wearing 2T clothes. He's just fine. He's as fine as the other one. And I think that that's a huge point to make, to cut yourself some slack. They'll be just fine. And that breastfeeding for me was probably the biggest thing, that it gave me the most anxiety out of everything. So really just, it will be fine either way. If you can do it, that's great. And if not, they'll be just fine.
Yeah, I pumped for a full year for the first one, and now we're at 11 months with the second one. But that is also, I agree, it's the most anxiety ridden thing, because you're trying to be like, oh, I only have, this many minutes between. And if you have a pump room we have 2 hospitals, it's in the old hospital. So to get there is like a 10-minute hike to get all set up. You pump for 15 to 20 minutes, clean everything. I mean, that's a good, 45 minutes to an hour. And I mean, to try to work that into your schedule, like as an attending, it's much easier. So Lauren, I commend you for doing it as a resident. I wouldn't be able to do that, but I at least can kind of work my schedule around it. But there are times when you're in the OR and either you can't scrub out and you kind of have to deal with that discomfort and pain. But I try to at least be very open with people. I say, this is going to be a long case we're starting. I haven't pumped in so many hours. Either I'm going to pump before we start, so we're going to delay the case a little bit, or else I'm going to need to, stop in the middle of it and go pump. It says I can't go another 12 hours without pumping. So at least in my hospital, they've seen me have 2 kids. It's kind of a routine thing and everyone's used to it. They all come in like, did you pump yet? Did you pump? Like the anesthesiologist, the nurses. So everyone is very worried about you. So it's nice that people ask me, but that is, I mean, it's been one of the biggest challenges. And once, you hit that year mark and I'm done pumping, it's like, I'm free. I don't have to carry around my pump bag. I don't have to, plan an hour into my day at certain points. So, if you can do it, great. And I've tried to do it, but I also see the hassle and the stress and the anxiety with doing it. So, I mean, whichever works for you, I think is going to be best for your kid.
Yeah, so right before, I gave birth, one of my really close friends, who's also a surgery resident, told me, out of all the things she's done, all the board step ones combined, running all these marathons, breastfeeding was the hardest thing she has ever done, including her PhD. I was like, and now I totally understand. It wears on your body, it wears on your spirit, being tied to like these machines. And it's really hard. I mean, I thought about giving up when I had my baby and my milk wasn't coming in. We had to, formula feed her for the first a couple of days. And yeah. And I also told myself, like, it's fine if, she doesn't end up breastfeeding, we'll just formula feed her and she'll survive. Plenty of people have done it.
It also adds another layer of complexity. Like if you're going to go to a meeting, this is something that I came across because I like to give a lot of talks or, participate at some of the annual meetings, obviously not with COVID, but what am I going to do with my milk? You know, there are companies that you can pump and they'll ship it to your house. I actually just brought my daughter with me for like the first 6 months. So any meeting I went to, my husband and my daughter were coming with me. They hung out at the pool or the hotel or whatever, because then I could, you know, go and feed her in between, you know, talks or sessions, or I could pump and at least give it right to my husband to feed her. But I mean, it's a whole nother level of trying to like coordinate and think about things. But you know, that's just something to think about too. So if you want to go to meetings or travel, that is another headache to have to think about. But
well, Catherine, let me tell you one thing on that front.
Yeah.
CNS annual meeting started having lactation rooms back in 2019, a designated lactation room for attendees. And as the vice chair for the annual meeting this year, I will assure you that I will make sure there is a refrigerator in there.
Okay.
And if you have ideas about what needs to be in that room or where it should be or what we need to do to make that easier at the CNS meeting anyway, please tell me, because that's a huge priority for us in that organization.
And I've used many of like the pods, or I mean, because we traveled a lot during my first year. And so I feel like I have a lot of the ins and outs for the breastfeeding rooms or those pods that they have in the airport and things like that. So yeah, I can let you know.
Yeah, tell me what works, because that's really, it's a huge priority for the organization. And like a lot of times we just don't, you know, people don't think about what pieces of the puzzle might be necessary. So.
Well, I think people might choose not to go to a meeting because of that. Like I said, I was worried about what I'm going to do with this milk and not getting it to her or her not being able to eat. And so I considered not going to meetings, and I'm like, nope, you guys are coming with me. And that was just kind of our thing for the first years that they traveled with me. But if you can't afford to pay for that extra ticket of your husband, I mean, that's a lot. You know, pumping or having those options are always good.
And hotels, they legally have to be able to store your frozen breast milk too. So they either have to bring up a mini refrigerator freezer for you in your room, or if they don't have those, then they have to store it for you in their storage system. So I mean, as long as you trust that hotel will do that in a safe place, they have to legally do that. And then also with traveling in airports, doesn't matter how much you have, as long as it's all frozen, you can get it all through. So you don't need to worry about that either.
Great tips. Well, we're heading towards the end of the hour. So I just had one more question for you guys, and then we're gonna open it up to our audience questions. And that is there a piece of advice that you wish that you would have had earlier, now having gone through this process? It's a stumper, apparently.
Maybe, think about what your needs are. You spend all your life trying to please other people, be the best that you can be at your job. But this is a really, really special time, not only for you, you're bringing a little one into this world, and it affects your family, other people involved in your life. So you are the one to advocate for yourself. So really think, just beyond what your immediate needs are, but, really advocate for yourself.
I think a piece of advice I have, and it's not related to neurosurgery or any job, it's really just a mom thing, is that don't compare yourself to other moms. Like I said, we have 4 women here. We all have different situations. We've all found what works for us. And that's what I tell people, find what works for you. It might not be, convenient for other people. It might be unconventional, but if it works for you, it works for you. And don't compare yourself to the moms that aren't working. Like, I'm never going to be someone that packs a little sandwich in with a cookie cutter shape and like all these little cute things. Like, I just don't have time to do that. And I've accepted it. But if you compare yourself to other moms that have different jobs or different lifestyles, I feel like you're always just going to feel bad about yourself. So I think just accepting what you can do, and it's the best for your kid, and it might not be the same as someone else, is a good way to just feel good about yourself and good about your situation.
I think my advice would be to find a community. It took me a long time to find a community of mothers who were in similar boats, whether they be neurosurgeons or elsewhere. I didn't know a single woman who was a neurosurgeon and a mother when I had my first child. and they were out there, and I didn't recognize how many of them there were. And once I started to engage with that community, it just made it so much easier to recognize that your own struggles are pretty universal, to hear about how people, have handled them, or just to vent. That's probably the best part of it. But look for that community and help build it when you find it.
And I guess the last thing I would say is, don't be afraid to accept help that is being offered to you. And I still have a huge problem with that, because the mom guilt is there and you want to do it all. As soon as you're not working, you want to do all of it. But if your mother-in-law is offering to take them out for ice cream, let them go. Let her bring them, and you can stay home and sleep for that 30 minutes if you want to. People are there and you just have to take it.
Thank you all so much for participating in this. This was a really great conversation. And we have a lot of good questions from our audience. So I'm going to start going through those. But I also just wanted to say to the audience that, there are a lot of different ways to be a mom and to be a parent, whether that's a single mom or adopted mom, or and there are a lot of other family structures other than just heteronormative marriages. And unfortunately, we don't have like the nuances of all of those perspectives here today. But hopefully this is opening the door to more of those conversations. And I think it's just important to recognize that this is just one. These are individual paths, and there are more. So with that, I'm going to go to our first question. This is about family planning, and it says, as a medical student, I've been cautioned against asking programs about their maternity policies while on the residency interview trail. What strategies would you recommend for finding out which programs are pregnancy friendly?
Yeah, so even as a program director, I would continue to caution you against asking those questions in most programs, because I think that it can come back to haunt you. I think that if I was applying now, I would look for programs where women had had children. When I was applying, I don't know that there was one, but now there are those, and I would intentionally try to seek out some of those programs. And then when you go to interview, hopefully, perhaps live this year, we pray. I would talk to the female residents that are there, and I think you can ask them probably those questions, or you can at least sort of start that conversation and see how that goes. In programs where there are no female residents, that's tougher, and there are some of those out there. And I think that you have to kind of feel out probably the program director on that, to say, notice there aren't any female residents here. Any thoughts about how that has, why that has developed that way, et cetera, and try to kind of ease into those conversations delicately. And then also build mentors in your own institution or elsewhere who can give you the inside scoop, because a lot of us know what programs are going to be more difficult for women than others. And we can, people like me and the other women on this call can help you figure that out by being candid with you.
This is a really interesting kind of follow-up question to that, that I have myself too, is, do you guys have any advice regarding the costs of associated with egg freezing, if that's something that you're thinking about, if you want to delay your pregnancy and you're thinking about freezing your eggs as a younger trainee without financial resources? And do you think that residency programs should cover the cost as maybe part of like a diversity budget initiative? We don't even have childcare paid for in most institutions. Is that for the ones that already, for the kids that exist? But what are your thoughts on that? I'm curious.
So since I actually looked into that, I had kind of got a cost estimate of what it would be. And kind of just like knowing that, I kind of figured what I would need to save if I did actually, proceed with that. I think there are some insurances, and I didn't look into the insurance route, that have different options for fertility, whether it be like an extra supplement you have to pay or something like that. But I feel like I've heard of some insurances that at least help with part of it, or, you know, you can have X amount of dollars that you could put towards something for fertility related, whether it be egg freezing or IVF or anything like that. So, but it is a substantial cost. So it's not something you kind of just want to do on a whim. If, you know, you just got to think about it. And again, when you're a resident, you don't get paid a significant amount. So that was kind of just my approach to it.
Catherine, when you went through that process, how time consuming was it going to be for you to, if you had gone through egg freezing? Because that's another piece that I don't know about, but I would imagine would be hard during residency.
Right. And so it was kind of in my mid residency, and I was thinking if I was going to do it, I was going to try to do it during research year, because you have to do all these hormones, you have to, you know, have multiple doctor visits. And so I said, if I was going to do it, you know, my research year is probably going to be the time that I would do it, because otherwise I wouldn't be able to take, you know, a day off, you know, once a week to do all these things. So it is a time commitment as well. I mean, and that was, gosh, you know, it's 7-8 years ago now, but, you know, things might have been changed. But again, that was kind of my plan. Is I was just looking forward down my residency and said, oh, I could have probably swing it when I'm a research person and I can have a little bit more flexibility.
As to the idea of residency programs paying for it, I think it's a great idea. You know, there's certain big corporations that do that, and I'm not aware of any residency programs that have, but you know, I think it's a fantastic idea, and it'd be a great way for a program to recruit top female candidates.
Yeah, I would think that if that's really their goal, more and more institutions are starting to have bigger budgets for diversifying their workforce, that might be a good investment for them to consider. So that's a great question. This is a question specifically for Dr. Wong, and it is, how did you approach career building as a physician scientist, and how did you plan your projects around pregnancy?
So it's tough. I think, you know, we're all juggling so many things, and then adding pregnancy and having children, it's just another piece in the grand scheme of things. So I guess the lucky thing is that I had Skylar at a time when I had gotten a series of grants. So my lab would be okay for the next year without actively applying for other grants. So basically, as soon as I started my faculty position, every single year, I think I've been putting in between like 3 to 5 major grants. And because the timing kind of worked out, so it was okay that, you know, I, for the next year and a half, kind of projected that I may not be as productive. And of course, a pandemic hit, that took a huge hit on research as well. You can't always plan for these things, and people just make it work. It's always challenging. And now, you know, 5 months out, I'm scrambling to try to put together an R01 grant next month. So it's a new level stress. So you always find something to stress about, and it's never going to end. So there's never going to be a perfect time, and you just try to do the best that you can.
This one is about planning for childcare. What's your advice for building a support system, childcare, etc., to make being a mom possible on a resident or fellow budget? So childcare being wildly expensive.
I guess I can partially speak to that. My husband is the breadwinner of our family right now, so it's not entirely up to my salary alone for childcare, but because I'm a resident, we ended up having a nanny in the very beginning, and we've had her for almost 3 years now. Her salary is essentially what a resident salary would be. And so you just have to be aware that you will be not going out to eat often. You might be cutting coupons, but it's definitely still doable. You just need to be much better at, you know, budgeting than maybe you had been before. And so childcare with nannies is a little bit more expensive. Daycare is a little bit less in most places, except for, I guess it sounds like places where Dr. Miller is, maybe that's not the case. So you kind of have to do what's best for your family. A nanny is doable even for people with one income, a resident income. I know people that do that. You just kind of have to be really good about budgeting, and having a nanny in your home definitely changes the dynamics in a good way. I think it gives a one-on-one relationship with your child, which is really nice for that mom guilt when you can't be there, that there's a person there that loves them and wants to be by them.
An au pair is a great option if you're on a tight budget as well, because then you have somebody who's live-in, and that can help you when you get called in at night, or with those kind of difficult hours. They cannot, depending on their program, they can only work a certain number of hours a week. And so I know people that have 2 au pairs, for example, to kind of handle things. But that's often a piece of the puzzle that can be useful on a budget.
And maybe talking to other, not necessarily in your specialty, but talking to other residents who have kids, because like Lola had just explained, there's 3 kids from the neurosurgery department that are in one daycare, but maybe talk to other, residents and see kind of where they have their kids in daycare or what they're doing, because they might have some tips or, good insight as to kind of how to plan or budget for that, since they're kind of in the same boat.
That's a good point. General surgeons seem to be a little bit ahead of us on that. So there are a lot more people that I know that have that going on as a general surgeon mother.
Thanks for that. Our next question is a great one. What are some things that male neurosurgeons can do as residents or faculty to advocate and help bring the needed changes to these inequalities and issues?
That's one thing that I was actually speaking just yesterday about with one of my male neurosurgery residents. He's the one that took the 6 weeks paternity leave off. And like we had mentioned earlier, one of the big things is to normalize both paternity and maternity leave across the board, so that what's fair is fair for everybody. And nobody can go out and say, well, they didn't get as much training as the other person, because everybody is given the same opportunity for these things.
Yeah, I think, especially for neurosurgical faculty and leadership, really trying to create a system where people take official leave time, FMLA, for the time that they take away is critical. Because when a woman has a baby herself, gives birth to a baby, she has to take some time off, because there's a physical component to that. When you have, so we all take FMLA for that pretty much, right? But when you have other people who are taking leaves of absence for other reasons, and they're not going through that formal process, it often is kind of not noticed, or it's not considered as disruptive to everybody else, for example. And so I think trying to make sure that the rules apply equally, and that means that the rules apply to dads the same way they apply to moms, and leave for other reasons. And encouraging the men in your department to take time for themselves and for their families. I think that when I have seen male residents in particular stressed about someone's maternity leave, it's often been because they felt like they didn't have the chance to take care of their family in the way that maybe they would have wanted to, or their wife would have wanted them to, or that sort of thing. So encouraging that type of self-care across the board is really good for women.
Exactly. And, for the male residents, faculty out there, when your wife is carrying your child, take the time, don't say, oh, I'm just going to take a week of vacation and come back to work, because you're actually not leveling the playing field, and you're actually indirectly discriminating against those that are carrying your child.
And as this becomes more common, I think men and residents are starting to understand kind of what goes into being a mom, whether it be the pumping situation. If they've had kids of their own, they see what their wife's gone through. So I think that helps. But if there's, people that, don't have any experience with their kids, or don't really understand like what goes into it, I think maybe just explaining it, because they just might not know that you have to pump, every 3 hours. They might have no idea that that's a common thing, because they've just never experienced it. So I think maybe educating them, and if they understand it, they might be, less angry or upset or confused about why you're, leaving every 3 hours, because they just don't know. So I think maybe some of the education would help them kind of further understand and be more accepting of kind of what it takes to be a mom.
You would think as doctors and healthcare professionals, they would know.
Let me tell you, you would be amazed because I gave a talk at the SNS, the Senior Society, 7 years ago on this topic. And part of my talk was about the biological clock and fertility issues. And all of these male neurosurgeons in the audience came up later and they were like, that never occurred to me. That yeah, by the time women are done with their neurosurgery residency, they might not be as fertile as they would want to be. I mean, it's not all of them. I don't want to paint everybody with one brush, but it's like, you guys went to medical school with me, right? It's amazing.
Yeah, there might be part of it that is the stereotypical men are clueless type thing, but also, I mean, I was clueless to a lot of the things too myself. I had no idea how much went into breastfeeding and countless other things.
Yes, that's fair. That's a fair point. So this is a follow-up question that is sort of on the same vein for Dr. Chambliss, and that is, do you have recommendations for innovative approaches for maintaining resident coverage while maximizing parental leave? So how do you deal with some of that, possible resentment and making sure that everything is covered?
So the way that I try to present it to the residents and dealing with this in a totally different situation right now is that, there's X amount of pain associated with somebody being gone, right? Being unable to take call, being gone for conference, whatever. And if you share that pain amongst like 2 or 3 residents, like the ones in their class, for example, like those people are feeling a lot of pain. But if you share it amongst the 20 residents that are there, we have 21 residents in our program, it's just a little bit of pain for everyone. And so that's sort of the concept I try to take to this in general, is that we have to find ways for everybody to pitch in. And so, if it's a junior resident call situation, that doesn't mean you have the chief residents take junior call. But what can the chief residents do to make the junior residents' life better while they are also having to take more call, for example? And what I try to get to know what each resident really needs or wants at a given time. And so maybe it's somebody who wants to be able to go to an additional meeting, and we need to we need to support them to do that in kind of exchange, for the fact that they're doing this extra work, but really just so that everybody feels like, we have a sense of what their own internal priorities are, and we're helping to support those. And so for someone that may be, the priority is I need to take this maternity leave. For somebody else, it may be, I really want to get to a couple extra scientific meetings. And so, if they're taking some extra call during that time, I'm making sure that they get that piece on the other side as best I can. The other piece of it to recognize is like, this is never going to be perfectly equal. Life and residency in particular is not fair. And things are going to come up in 7 years that you didn't anticipate, and you're going to have to deal with them. And we try to talk about that really on the front end, just to try to help everybody recognize that at the end of the day, you never know what's around the corner for you a year from now and what you're going to need from your community, your co-residents. And so, we try to have the karma approach, which is like, let's build karma along the way so that when we have to draw from the karma bank, we've put something in there and we feel better about it.
Do you guys have an actual policy like written out, kind of like, okay, if somebody gets pregnant during year 1, this is what it's going to look like year 2, this is how we're going to manage things? Or is it just, it's kind of like a case by case?
It's more case by case. I would love to have a policy for everything. That's like my personality. I would love to have a plan for absolutely everything. And when I started in residency administration as an associate program director, that's what I did. And I was like, this year it's going to look like this. And then this year, because we were transitioning over time from a 2-year to 3-year program. And what I've learned is that you can only plan a year in advance in a residency, because you just never know what's going to happen. Someone's going to want a year extra research year. Someone is going to quit. Someone is going to have a baby. Someone is going to have, this issue come up. And so we really deal with it on a case by case basis, because otherwise I would have all these policies and then I'd be constantly revising them. And I've learned that's a waste of time.
Yeah, that's a great point, that also like people leave the residency program. It's not uncommon, and if they're able to figure it out when people quit, right?
Yeah, and that's far more disruptive to residency, and we've had that happen, and it's very difficult for the people around that resident. And again, you just, in my mind, you try to just share that across the entire group as best you can, and then they also need to see that the faculty are pitching in some way. And so, we have something like that going on. We say, like, what are we asking you to do that's maybe not really helpful for your education that we could maybe pull back on, because we recognize that you're having to do some additional work in this area.
This is a question for Dr. Wong, and that is, what is your advice to a dual surgeon households?
Well, I think it's actually worked out in our favor in that we both work for the same department, and everybody's aware of our situation. My husband's a lot more busy than me clinically, but he actually shares a lot of the child caring needs, and he loves spending time with her, and it just that we understand each other in terms of the scheduling needs, and we'd never have to kind of apologize like, oh, I need to go out to this referral dinner to build up my clinical practice, or I need to stay extra late to finish this grant. So it actually works out pretty well in our favor. Obviously, we have help and we have the resources, in terms of parents, to help with childcare. Yeah, so that's my 2 cents.
This is a question for everyone. What are some things to consider other than salary to help support you? So salary, it sounds like childcare obviously is huge. Are there other things that help support you?
I think Lola had said this earlier, just having a community to kind of lean on. So finding other moms in the area, whether it be having family nearby. I think just some avenue to either de-stress or to just, get advice from, things like that. All of those are helpful, whether it be in the medicine field, whether it not be at all. I think just finding someone to help you, kind of support you in that way. It's always nice to have family. I mean, that's one of the biggest probably regrets I have, is we have no family around here. So like being able to run to the store without a kid, just have your parents come and take them is a huge thing. But I know that's not realistic. You can't always live by, your parents or family to have that. So I think maybe finding that community, whereas if you're like, I just need to run to the store, can I drop my kid off at your neighbors? If you know them, that's always an option, and it helps with your flexibility and being able to get stuff done.
Dr. Sand, do you have family nearby as well?
My husband's family is from Minnesota, from here. So I was fortunate enough with having that. Our nanny does 10-hour days, Monday through Thursday. And then my mother-in-law actually has, since my first one was born, has taken care of our children on Fridays. So that has been essential in making it work. And also it's really nice having a family member to care for your children as well, although nannies and au pairs do become family as well. So we have that. And then my parents live in Texas. My family lives in Texas. And what we are likely thinking is that we will probably remain around family in some fashion. And so hopefully we'll be fortunate enough to have that opportunity to do. So I think that is very important if possible.
We have a question here about what a typical week looks like for you, and how much time how much time is family time and how much time is work time. Who wants to start us off?
I can take that one if you want, because my week is very regimented. It's the same every week. But as I mentioned earlier, I'm divorced now, and that adds, complexities to being a parent and a neurosurgeon. But it actually, I've tried to take advantage of the things that it does offer on the plus side, which is that there are some times of the week where your kids are not totally your responsibility. Now, say for me, I sort of always feel like they're my responsibility, but it actually is, helped me to build a little bit of work-life balance that I didn't have before. So for me, my ex-husband has the kids on Monday nights and Thursday nights. And so what that means is Mondays and Thursdays are my OR blocks. And those are the nights that I take call. And so I do skull-based surgery. So I might be doing an acoustic that might take 18 hours or something. I do it on those days, and I know that I can be totally focused on my cases and call responsibilities on those days. And then I have clinic and academic time the other days, and then, of course, weekends, call, et cetera. So I'm all OR for 24 hours on Mondays, run 2 rooms like crazy. And then Tuesday's academic day, where I already mentioned I get a lot of time with my girls in the afternoon. Wednesdays I'm in clinic, and then I get to pick them up after their dance lessons. And, then back on Thursday, I'm back in the OR. Friday is sort of a flex day for me and can go either way. And then I have lots of time with them then and on the weekends. One other thing that I negotiated when I became the program director is that, you have to have some degree of protected time for that. And the thing I really needed was a little bit less weekend call, because that really impacted my ability to be with my girls on as many weekends as I have them. And so I negotiated to have that piece of my life be part of my 20% protected time that's required by the ACGME. So I still do take some weekend call, because I think it's important as the PD to do that, to see that. But I do that on weekends that I don't have my girls, and then I can be totally focused on the work piece. So my situation is obviously different than everybody else's, but that's how my week looks. And it's taken me like 9 years to get it dialed into that. And now I really, really like it.
That sounds really nice. I hope that I get there one day. Right now, as a resident, people do things differently, and you have to do what's right for you. But I've just decided that what I'm doing while I'm a resident is work and be with the kids, and that's it. I don't, really have a life outside of work or being with the kids, and I'm okay with that right now, because I get so little time with the kids right now. So the workouts have kind of been on the back burner. Friends have kind of been on the back burner, but people understand there is light at the end of the tunnel, and it's not even just a tunnel, I guess. So I shouldn't even say that. You are having your life during these 7 years with kids, if you choose to have kids. So it's part of it all.
So in terms of my typical work week, I operate about, depending on the week, 1 to up to 3 days a week. So every Friday I operate, and then scattered around like Tuesday and Wednesdays. But, my schedule is actually a lot more flexible now, because I'm 50% research. So the other time, I'm in my office working with lab stuff, but the hours are flexible. So in case, I need to go pick her up early, or, even if I want to play hooky and like take her to the zoo, I could do that. So it's really nice. And I think it comes with, being having the flexibility of being an attending. I can't even imagine Lauren, and Lola during, those very regimented training times, and Katie too, how you're able to do that. So I really applaud all of you guys for going through that and paving the way.
Yeah, and my situation is just a little bit different. Like I said, I'm either on call every other night or every third night. So we are at a trauma center, so who knows what's coming in or what my schedule is going to be. I have set OR days and I have set clinic days, but probably at least 50% of my cases are traumas coming in. So they happen when they happen. I'm very OCD, and I think Lola's probably the same way. I like things very scheduled. So usually like 5 or 6 to 8 or 9 is my time with the kids. The ER knows it. My colleagues know it. Everyone knows it. So even if I'm on call and it's not an emergency, like that's my time. I feed the kids, I get them baths, I get them to bed, and that's my time with them. And so I've made it very clear to everyone. I said, if it's an emergency, you obviously call me. If it's someone with back pain and they're not dying, just call me like after 8 and I will come and see them. And so that's worked out for me. I've been up front since the beginning, that's like my chunk of time every day with the kids, and they expect it too, for when I can spend time with them. The rest of it, who knows? I might have a scheduled OR case, I might do emergent crani, that can be up in the air, but I try to kind of carve out these few hours with them that's consistent, so they know to expect it. Everyone around me knows. And if it happens, very rarely does it not happen. It's every once in a while, and I'll Zoom with them. But other than that, that's kind of a recommendation I have. See if you can try to carve out a piece of time in your schedule, and then do your work later in the night or earlier in the morning when they're sleeping. So you can be able to have your time with them, but also get your work done.
Yeah, related to your OCD scheduling, are there any time management tools that you use that you recommend? Any?
Well, my son, who's 11 months, doesn't sleep through the night. So I'm averaging like 2 hours a night of sleep for the past year. So he is like my best time management.
For that
makeup right now. So like when I'm up with him and like rocking him or playing with him, like I have my chart ups, I'm reading notes, I'm like chart checking. So I try to multitask. And when I'm up in the middle of the night, like I'm trying to get as much done as I can. And like I said, when they're asleep, that's when I do all my other kind of clinical stuff. I don't have an app or anything like that. I'm inherently, like I said, super OCD. So it's kind of just my personality, and I kind of just get a system going. But I'm sure there's apps and stuff. There's an app for everything nowadays. So I'm sure there's things that can help with like scheduling and timing of stuff. But
Dr. Miller was my chief resident, and I have always been very envious of her ability to schedule things internally, unlike myself. But one thing that that my husband and I do is we have a calendar that's just a written calendar up in our kitchen, and we write everything down so that there's no confusion about days that we're not here, we are there, and the chaos that goes on throughout the week.
Super analog. I like that.
Old school.
Yeah, I like that. Okay, well, one of our next questions is, as a resident, when is it appropriate to tell your program director and fellow colleagues that you're pregnant? And is there an advantage to telling them you're considering pregnancy at a certain time?
So I think that this is very dependent on your relationship with your program director in particular. In my program, I would say that for my female residents, I think there's a huge advantage talking to me about it early and even before you're thinking about it, because I'm going to give them a lot of support in terms of making sure they can make it to appointments, thinking through what we need to do long term, and obviously keep that confidential. And that's like a critical part of my job, of course. But it depends. It definitely would not have been the case with maybe when I was training, although I didn't even know I was thinking about being pregnant, so that wouldn't have had anything to discuss. But I think it depends on that relationship. The other piece to realize is that very sadly, but realistically, not all pregnancies end in a healthy baby. And miscarriage is a major reality for many women. And so, if you get pregnant, you find out you're pregnant, I think a lot of the decisions about when you're going to discuss that with other people is related to the fact that that is a concern. And it may mean that you tell people earlier, because you may recognize that you would need time away for that as well. And if that was to occur, that you would want somebody in leadership to know. It may be that you really want to wait because that's something that would be very difficult for you that you'd want to keep private. And so I think thinking through how you would handle all these eventualities kind of dictates when you would have that discussion, and it's going to be very individual.
That's a very good point. Miscarriages are so much more common, I think, than people talk about. And so that is a huge reason why some people keep that to themselves, like Dr. Tremblay said, and that's totally up to you.
What are your thoughts? This is kind of a question for everybody. What are your thoughts on trying to have children during medical school versus residency? Do you guys know anybody who came into residency who already had kids?
I do know some, including some surgeon mentors of mine, and they all say that it was a good time to do it. I didn't experience it myself. I was not nearly mature enough in medical school to have a child, but I've definitely heard people say that it can be a really good time. I think the downside for me would then be looking down the pipe of 7 to 8 or 9 years of training during that while you had a child the entire time, and that sounds challenging to me, but I don't know what others have heard.
That's a good point. I know a few people that have had children. I think it seems like it's easier when you're in medical school to have the child, but then while you're in residency, they're at the age where they have like soccer after school, and they have school events, and it's a little bit busier, it seems. I don't have any kids that age yet, but I would imagine so. it's a little bit easier if they're younger. While you're in residency, they just kind of hang out at the house or a daycare.
Yeah, I didn't really know too many people in my medical school class that had kids while in medical school. But yeah, just knowing that residency, it's very regimented and you're not in control of your schedule at all times. I mean, it can influence, how much family time. But again, like I said, if you're coming into it, there are innovative ways or, ways that you can make it work, kind of coming into it, and kind of you can think about that if you do have kids in medical school, about how you can try to, like I said, customize it for what works with you and your family.
I will add also, unfortunately, I do think that there is still some discrimination against residency applicants who already have children, who are female only. And I have seen that in some mentees of mine who have ultimately gone on to be spectacular neurosurgery residents, but probably struggled to match, in part related to a perception that they might not finish, or they might not be fully dedicated in the way that a resident who was not a mother was. So I think that can be a challenge.
Maybe something not to mention again during interviews.
Yeah, hard to know. I think when I have mentored students in this situation, we have been upfront about it, and I've included it in my letter's recommendation to say, because they're talking about it in their personal statement, et cetera. And I say, this person is a mother. I've worked with her for years. She's a fantastic mother, but also a fantastic student. And, I see no issue with her being able to, perform all these duties as a resident, et cetera. But because I think it'd be hard to hide. And if you match in that program and then you show up with a child, that would be difficult. But I don't know. I tend to think honesty is generally the better policy, but you also have to be very protective of your own interests and recognize that these discriminatory issues may occur. And sometimes that may mean that you do need to be more private. I don't know the answer to that question.
Do you give the same advice to men who already have kids that are applying to residency programs? Is it the same?
Sadly, it's a very different situation. I don't think it matters at all. And in fact, you often hear programs being like, oh, we're really family friendly. We want more residents that are married and have children, but they're usually not imagining those to be female residents, I think. And I don't want to paint everybody with one brush, but I think that's certainly the stereotype.
Mm-hmm. Yeah, this is kind of on the same, it's a similar question as, did any of you, when you were interviewing for a new job, did you talk about your need for flexibility or your plans to have a kid when you were interviewing as a resident or a trainee?
Well, I remember when I was interviewing for residency, I got asked, and which is completely illegal, if I had kids and if I was planning on having kids, multiple times, like flat out. And to that, I just said, I don't have any plans. I mean, but it was like that they're not supposed to ask you about that. I know it's very bad, but I think that is hopefully the culture is changing where that's not being asked, but I think that's definitely influenced, applicants and things like that.
So Catherine, we've got a paper coming out. I think it's coming out in JNS. I'm a collaborator on it, but first author is Natalie Limoges, who's a mom and a neurosurgery resident in Vermont. That is a survey analysis of applicants post-match about how many were asked illegal or inappropriate questions related to parenting, childcare, but also race, ethnicity, et cetera, et cetera. It's not shocking to any of us that have been through this process, but yes, the vast majority of applicants are asked questions that are illegal or inappropriate. So stay tuned for that paper. But yeah, I think I always tell our female applicants, prepare for that. You're going to get asked, and the way that I generally advise people to respond is to say, I don't know where I'm going to come down on, having children eventually. But what I do know is for the next 7 years, I'm going to be, my neurosurgery training is my top priority. And just leave it at that. And whether that's true or not, doesn't matter. It's, somebody doesn't have the right to be asking you that anyway. And at that point, I think being honest is probably less of a concern, because you get into that mode where you just got to protect your own interests.
Yeah. Right. And then beyond residency, when I was applying for jobs, luckily I didn't get asked that question either way. But what was really nice is actually my mentor and also partner currently, when I was about to sign on for the UCSF job, he actually approached me and said, you should think about having family. You should do this, and it's totally okay. And take all the time that you need. We're very supportive, and that meant so much to me. Because I feel like pregnancy, childbearing has been just like, don't talk about it, don't ask, don't tell, kind of. And for somebody who I really respect and in leadership position to come out to me and say that out, right, was really nice.
My boss did that for me as well, my chairman, which meant a huge amount to me. And so now when I'm interviewing residency applicants that are female, I always say, you don't need to tell me anything about your plans, but just so you know, we have residents who are female, who have children here, and it's great and it's wonderful and we're supportive. And when we have female faculty interviewing, I have the same conversation with them. Because I think, so for people who are faculty on this webinar, thinking about things you can do to help, being proactive about that, I think could be really helpful, because then sometimes people have follow-up questions and they do really want to talk to you about it, and that invitation to have that conversation is important.
This is one I think that maybe we touched on it a little bit earlier, but maybe to put a finer point on it is that how do you deal with fellow residents who are just not supportive of your leave? Like if you're experiencing microaggressions or negative comments, like how would you, I mean, it sounds like everybody here has had a pretty good experience and that hasn't happened, but you hear a lot of things in researching this topic on the internet about some pretty nasty things that are being said. So how do you deal with that?
Oh, I was smiling because I didn't have microaggressions. I had some macroaggressions. I mean, when I told my co-chief that I was pregnant, and his wife had just had a baby, and he'd taken some time off, and I told him I was pregnant. He was like, "This is the worst thing that I could ever imagine happening." I was like, "Okay, excellent." And for many, many years after I graduated, people who were in my residency with me said that I did a 6 3/4 year residency. And they said, well, it's 7 years for most people, but it's 6 3/4 for some. And that was really painful. So, I don't know that there's necessarily that much you can, for me, there wasn't necessarily that much I could do in the moment other than to try to make things better. And I work in my own program, so I think I tried to do that. But in the moment, I think the best thing you can do is just kind of realize you got to look out for yourself in it. You can certainly try to use some rational thinking and say, look, everybody takes time, everybody needs that time. But I think probably more importantly, you have to let that kind of be over there and look for a community that's going to be able to support you and lean into that community.
And I think one thing, even though everybody's super supportive, it still bugs me when people say you're taking time off. As if you're like on vacation, sitting around. They don't understand you're like in physical pain 24/7 for the first, X number of weeks. You're waking up chronically sleep deprived. And what I try to tell people, like my residents, it's like, I went through a pretty tough residency, but I would much rather take call, neurosurgery junior call, like chief call of the county where you were practically there the whole time, than, the maternity leave. It's not vacation at all. It's much, much tougher. And I think just making people maybe realize that, hopefully that will, make things better and reduce these micro or macro aggressions.
Yeah, I have two male partners. We're in a community hospital just north of the city. And so having two male partners, they actually were completely fine with whatever amount of time I wanted to take to try to, I guess, pay it forward to them. I offered to take more call. I said, I would make up my 3 months of call, but which they refused. But I worked till I was 40 weeks pregnant, and I made them induce me. So, it wasn't like I was slacking and things like that. I didn't take call the week, before I was due, because I didn't want to have an emergency. But I think people realize how hard you're working, that you're not slacking. And I think that helps with it. I mean, but again, like Melissa, there's some people that are just going to be negative. They're about anything, regardless of what you say, what you do, and you can't take that to heart because that's just a problem with them and not you. And, you know, you're doing what's best for you and that's all you can do.
You're muted, I believe.
Dr. Sand, do you have any advice for people dealing with unsupportive colleagues who are just not hiding it?
Yeah, I mean, I think it's human nature to want things to be fair or seen as fair. And in reality, like Dr. Wayne said, they can't be in physical pain. It just biologically they can't be. But having the paternity leave normalized, I think will at least help some of that idea of fairness, so that they feel that if you got the 6 3/4 residency, that they did too.
We have an interesting comment here that says, to shift it, I find it really interesting that pregnant women keep working in the OR. I come from Germany, and here it's against the maternity protection laws to operate when you're pregnant because of potential risks. Do you think that should be implemented in the US?
Wow, that's interesting.
Yeah, that is really interesting.
So there's actually, great literature on this, which, I try when I have these conversations with men in neurosurgery, I try to be very data driven. So there's great literature to indicate how to operate safely in the operating room. And it mostly comes from the nursing experience because, of course, there have been nurses in the operating room for hundreds of years and long before there were very many female surgeons. So there are specific accommodations that need to be made regarding radiation. And there's very good literature on that. There's a few things in the operating room that can be teratogens, so methylmethacrylate, for example. And so, you need to avoid using that if you have pregnant people in the operating room, but there's great alternatives to that. So, my personal feeling is that it absolutely can be safe and women should not be excluded from operating during that time, because I think that would wreck the notion of mothers being able to be neurosurgeons. But you absolutely need to know that stuff. And I wouldn't expect your hospital to know it for you. That's another area where information is key. You're gonna need to educate yourself before you are in the operating room in that setting so that you make sure you're protecting yourself and your baby.
Yeah, I operated up to I was 40 weeks, both kids. So I mean, I think it's definitely doable. I mean, I wasn't doing huge scoli cases, so I wasn't doing 12, 14-hour cases by the end. But I was on call. I couldn't not do a case because, I didn't want to or I didn't feel well. So I think if your practice allows it, maybe that's an option. But at least for my practice, I can't take call and not operate. But I mean, I was fine operating. Like I said, if I needed to sit down, I sat down. People would bring me water, people would bring me candy. I mean, everyone's very receptive. As soon as I walk out of the OR, someone has a sandwich and a little Sprite for me the second I get out of the OR after operating, because they all know, it's in the middle of the night and I'm pregnant, and, people make adjustments and try to help you out. So I think it's definitely doable.
Dr. Wong, you operated pretty close to your due date as well, I remember.
Yeah, I think 35, 36 weeks. Yeah, I mean, I think there's definitely ways to do it safely. And, we're doing this because we also love operating. I just can't imagine being not allowed to operate for 9 months. That would actually personally drive me insane. And also to be able to keep up my, skills and such, it's better for my patients. And I think it just demonstrates we are, we can do it. So I wouldn't support necessarily a policy where you're not allowed to operate because you're pregnant.
Well, we have about 5 minutes left. It went so fast. So I think that this is kind of a general resource question, and that is, are there any books or online resources you would recommend that helped you through the process of pregnancy and mothering as a surgeon? Is there anything you would recommend that people get their hands on or check out?
I think talking to other people who've been through it. So I remember very distinctly, I went to one of the neurosurgery research grant, like the K-12 meeting. And at dinner, I was sitting around with other faculty, female, who talked about openly like the challenges of lactation, having a baby, studying for boards, writing grants throughout this whole process. And that was the most empowering thing. Just knowing that there's a community out there who can give you advice, who's been through it. It's way more helpful than those baby pregnancy books. I personally actually did not read any of them, and still haven't, just because they set up almost unrealistic expectations. They don't know your situation, your challenges, your family structure. So I think what Lola, everybody has said before, just finding that community, that's really, really key.
One specific group that I'd recommend for anybody who is in training or beyond, that's a female neurosurgeon, is a Facebook group. It's a private group that is the Neurosurgeon Women group. And that was developed as an offshoot of the Physician Moms group. And at first it was Neurosurgeon Moms, and now it's opened up to all women starting in residency and beyond. And there's I was just looking for there's about 130 members on there. And it's like a super supportive group where we also talk about like clinical questions and like stuff. We have arranged some meetups for upcoming meetings and that kind of thing. But I just couldn't believe there were that many. I think when we started that there were like 50 women who were neurosurgeons and moms. And I was like, I didn't know there were that many in the country. It turns out there are. And that's, now social media can help connect us in ways that, weren't there 10 years ago. So I'd strongly suggest if you are a trainee in neurosurgery and you're interested, just send a private message to the admin that runs that group, which you can find if you search Facebook. And also you'll have my email address at the end of this, and you can email me if you can't find that. But I found that really helpful.
I totally second that. Dr. Chambliss told me about that Facebook group when I had my first kid, and it has been in many ways a saving grace. It helps you feel like you're not alone in this. My husband, he's probably annoyed about how many times I talk about that group. So I would definitely check that out.
I'll also add, just mothering aside, groups like that are fantastic for career development. We, on that group, we started some chatting about people in academics that needed to be invited to give grand rounds or visiting professorships at other institutions. And from that, a bunch of us have given talks for each other's institutions, et cetera, that's really enhanced our CV when you're talking about promotion and things like that. So, those kinds of communities go beyond just mothering, though they do definitely address that piece too.
Well, it looks like we're at time. So I want to thank everybody here for joining us, for volunteering your time for this discussion today, and for all of our attendees for joining us. We are going to put email addresses for the panelists in the chat. So we got through a lot of questions, but unfortunately not every single one of them. Hello. This is Harper. Hi, Harper. We didn't get to every single question, so if you have follow-up questions, please reach out to them. They're happy to hear from you, and we'll put their emails, like I said, in the chat. And thanks again. Hopefully we can have more discussions like this around parenthood and neurosurgeries, not just moms, dads too, and normalize this for more people, because it's a really important issue. So thank you, everybody. Have a great day.
Thank you.
Thank you.